Hi everyone, this is Neil Writer, consultant, audiologist and director of ClearWax. Thank you for joining me in my latest video using the iClearScope endoscope. And this is of a patient who actually attended today, and I'll give you their case history. For the last couple of years, for no apparent reason known to them, they've been starting to develop earwax in both ears, and they don't live locally per se, but where they do live, it's not a million miles away, but they've got a local clinic and they've been going there. I think they visited them over the course of the last 2 years on 3 occasions. Now, on the last occasion, which was about a week ago, they had to have a couple of visits, and that's because they were told the wax was really stubborn and it was difficult to remove. On both occasions, the person that they saw used both microsuction and irrigation, and they were able to clear the patient's right ear, but they informed the patient that their left ear, there was some remaining wax really deep up against the eardrum, and obviously they weren't comfortable attempting to remove it. So this patient, one of his work colleagues actually watches my videos and says, you need to go and see the wax whisperer. And the chap Googled me and came across my website and booked in. And when I was taking the case history, they informed me that they suffer from a skin condition, but also they were type 2 diabetic, and upon attending, they were under the impression that this is full of wax. Now, they also do have a history of otitis externa, so they have suffered from ear infections in the past, and they've been prescribed a topical antibiotic called Ottomise. So Ottomise has basically 3 active ingredients. It contains dexamethasone, which is a steroid, which helps to reduce inflammation. It contains an aminoglycoside, which is an antibiotic, and more specifically, it's neomycin. So what the aminoglycosides do, they don't necessarily kill the bacteria, but they prevent it from reproducing. So they inhibit one of the subcomponent of a ribosome. So ribosomes are organelles within a bacterial cell. We also have it in our cells as well. And they basically help to translate and transcript proteins for cell replication. So they inhibit one of the subparts of a ribosome, therefore preventing it from reproducing and exponentially growing in the ear. And the other component is acetic acid. So acetic acid helps to reacidify the ear, and that's quite important with ear infections, because when you do have otitis externa, so an outer ear infection, the pH level of your ear, which should be mildly acidic, becomes a bit more neutral, and it then allows more pathogenic bacteria, which are neutrophilic, to colonize and then exponentially grow in the ear, leading to an ear infection. So the introduction of acetic acid helps to re-acidify the ear, helps the ear to become more acidic, therefore preventing the colonization and reproduction of more harmful bacteria. Now, patients who are diabetic are more prone to developing ear infections, and also once they've got an ear infection, it's more difficult for the infection to be treated. And that's because we all produce wax to various degrees, and you may not necessarily see the wax, and when someone examines your ear, it may look pristine, but there's a thinnest veneer lining the ear canal. And in patients who are diabetic, the earwax tends to be less acidic. So in the normal pH of earwax is between 5 and 5.5. But in patients who are diabetic, the earwax tends to be a bit more neutral in pH. Therefore, it doesn't have that acid mantle, and that acid mantle, as I explained with the acetic acid, is quite important. It helps to prevent more pathogenic bacteria from colonizing and then leading to an infection in the ear. And also, the oily sweat secreted by the ceruminous glands with patients who are diabetic, there tends to be less antimicrobial peptides, or proteins secreted by the ceremonous glands. So this oily sweat, it's not only sweat which is mainly oil and lipid based, but it also contains proteins, and some of these proteins, so these peptide chains of peptides, have antimicrobial properties. So patients who are diabetic, they produce less of those. And also patients who are diabetic, similarly to more elderly patients or patients who have undergone radiotherapy around the head and neck region, which may have affected the ear, there's less blood flow going to the ear to help fight off the infection. So patients who are diabetic, if you're going to perform irrigation, you must proceed with caution. And in this instance, particularly the second time they visited a specialist, they shouldn't, in my opinion, have irrigated the ear. If they took a full history and understood the patient's diabetic, they've also got a history of otitis externa, which, again, should be more of a reason not to perform irrigation. Now, I'm not the biggest fan of irrigation. I can understand why sometimes people perform it when you got kind of wet, sloppy wax up against the eardrum, for example. It can be very, very difficult to remove with suction or manual instruments. So I understand why, but although I'm trained to perform irrigation, it's not something that I perform in my clinic. I do manage to remove even the sticky consistency wax from off the eardrum. We use a fine end suction probe and we have intervals, so you're not overexposing the patient with the noise. So this patient, I don't know exactly what was going on. Obviously the patient themselves don't know. They were told they've got earwax, but there's no earwax in the ear. So I'm not sure whether the other person mistook that layer of skin on the eardrum as being earwax, but it's not earwax, it's an infected layer of dead skin. So this could be classified potentially. Now, this patient may have attended with otitis externa to the other clinic. I'm just not sure. Or this infection may have been secondary to the irrigation. So with water, what water does, so the water that's used typically for irrigation is actually tap water. So in the UK, so I know other parts of the world, they use saline water, and some even use sodium bicarbonate drops as another solution. But typically it's tap water, and there is tablets there trying to kill some of the bacteria, etc. But tap water in the UK, it's more neutral than pH. So first of all, it elevates the pH level of the ear, making it less acidic and therefore more susceptible for pathogenic bacteria. The water as well can contain one particular bacteria called Pseudomonas aeruginosa, which can lead to an ear infection. That's a neutrophilic bacteria. It's a gram-negative bacteria. So you get two types of bacteria, gram-positive and gram-negative. Now, a gram-positive bacteria has a thick cell membrane. With a gram-negative, it actually has a very thin cell membrane, but it's encapsulated in a lipid kind of solution. So, and that lipid solution makes it more difficult for gram-negative bacteria to be treated with antibiotics. It's kind of more resistant. In addition, gram-negative bacteria can mutate to become resistant to the antibiotic and then share that mutation with surrounding bacteria, so it can spread. Another thing with water is the skin that lines the ear canal. It's actually the skin cells themselves are hydrophilic. Now, there is some keratin within the skin cells that is hydrophobic. So, because we do want the outer layer of skin to absorb some moisture from the environment to keep it hydrated, but not too much. So there's a fine balancing act there. But if you've got excessive water in the ear, not only can the water strip away that natural veneer of wax, which actually sometimes is invisible to the naked eye, which we want, because that natural veneer of wax, it maintains that acid mantle to help prevent ear infections. It's hydrophobic, so it helps to repel excessive water from out of the ear. And it also helps the underlying skin to retain its internal moisture so it doesn't dry and crack. So particularly warm water, it can leach away that natural veneer of wax that's sitting on the surface. And then if the water gets logged in the ear, the skin cells themselves can overhydrate, they can overabsorb the water, and it causes the outer layer of skin to swell and then burst at the membranes, and it macerates, it breaks up the outer layer of skin, and then you're more susceptible to developing an ear infection. So this is this layer of skin. I'll just come back to the procedure. So it's really, really tricky, and guys, there's going to be some leftover. It's not just when you watch the procedure, it kind of, I know it just looks like a big circle and we've got an instrument and it's pretty straightforward, but it's not. The ears, this ear in particular, is very, very narrow. There's a bit of edema swelling at the entrance. You can see it's really red. There's a lot of erythema there. Removing this skin off the eardrum is really, really challenging, and it's not procedures I enjoy doing, if truth be told, because you need such a steady hand. So I'm trying to peel this away, and because it's a narrow ear, there's not much wriggle room. You can see when I'm pulling that skin down, the suction tip is almost going to be touching the floor of the ear canal, and that's a bony part of the ear canal. It's very sensitive, so there's very limited manipulation here. So I'm going to use the forceps in a minute, and I thought, brilliant, it's going to come away, but the forceps just cut away the skin, and it actually made it more harder to remove in the end. So going back to water and irrigation, particularly in patients who are diabetic or who are immunocompromised, who've got a weakened immune system, so therefore if they do get an ear infection, it's more difficult to treat, or elderly patients or patients who have undergone radiotherapy around the head and neck, which may have damaged some of the blood vessels, so there's less blood flow in those patient populations, and therefore more difficult to fight away infections. It's a very rare condition, but it's called necrotizing or malignant otitis externa, and that's when sometimes the bone around the ear canal can get infected, and so the temporal bone, and we call that osteomyelitis, an infection of the bone, and it can sometimes happen secondary to irrigation. So it can be an iatrogenic cause where it's caused by a procedure. It's not always typically just by the introduction of water, unless it's the infection. This infection doesn't go away. What the infection can do, where the cartilage portion of the ear canal, the outer third, meets the bony part of the ear canal, so the outer third, the osteocartilaneous portion, underneath that skin, there's natural openings called the fissures of Santorini. So it's possible for the infection to spread out from the ear canal through these natural openings and then infect the surrounding bone. And then this bone can get infected and it can spread all around the ear, around the jaw, the mastoid bone, and worse still, it can go towards the brain. And it can lead to a brain abscess, meningitis, and potentially death. And I did read somewhere that if the malignant otitis externa, so this osteomyelitis, this infection of the bone, spreads to the skull base, there's a mortality rate of 30%. So it can be potentially life-threatening. So it's a very serious condition. So it can be, if the water's in there for a long, long time, then they develop otitis externa, and this otitis externa, it's persistent, it doesn't go away. But sometimes normally it's also triggered by some trauma caused to the ear canal, either by an instrument that we're using, or the patient scratching their ear. And by scratching the ear, they can break up the outer layer of skin, so the infection can go through the skin, through the fissures of Santorini. Now, hallmarks of malignant otitis externa is, and it just doesn't happen in patients who are diabetic, immunocompromised, or elderly who have previously undergone radiotherapy. It can happen to anyone, but they're the patient groups that typically it does occur in. But it's a very rare condition. So I've managed to get some, I'm going to try, I think I might have missed it, but try and get some wax, not some wax, that infected dead skin off the eardrum. It's really, really tricky because they have got really, really bendy ear, and obviously you can't see it, but the way I'm stretching the ear and angling the suction tip, and I've curved it as well to get past that anterior canal wall, and you can see it's coming away. And the patient, although we didn't make contact with the eardrum, the patient did feel that kind of stripping away. It was not too uncomfortable. I don't want to cause any trauma to the ear canal, so I've had one more go. So you can see the majority of the eardrum now, so they can certainly hear better. We did a pressure test. The eardrum is vibrating fine. Sorry I'm speaking quite quickly without taking pauses. That's probably me normally anyway, but I just want to talk about everything that I'm talking about within the video. So going back to malignant otitis externa, so they're the patient groups. So I would kind of, and the hallmark symptoms are not only the patient populations I've explained, but they generally get severe pain at night, nocturnal pain. And that's because if you've got pain related to the bone, it's more notable at night because you've got cytokine storms, you've got more inflammation, you've got less endorphins being secreted, which are anti-inflammatory, less cortisol being secreted as well, which can all help reduce inflammation created by the cytokines. So it's all to do with circadian rhythms, to kind of daily rhythms. So at night, you generally get more inflammation. So it's people suffer from jaw pains and jaw joint pains. It's normally worse at night. And they also get granulation tissue, so inflammatory tissue, extending from the fissures of Santorini, where the cartilage portion of the ear canal meets the bony part in the outer third, and it normally rises from the floor of the ear canal. Now, there was a bit of dead skin here, a bit mushy, and I'm trying my best to remove that. Again, it's really, really tricky. But because this patient's diabetic, I don't want to scratch this patient's ear. I've got as much as way I can. I'm pretty sure everything's fine underneath because it's just mushy skin like everything here. But in an ideal world, just wanted to see if I could clear that, just to make sure there's nothing sinister going on around. But I've removed the majority. I can't see anything sinister to the naked eye there. So this patient has been referred to the GP. They do need antibiotics, and as soon as possible, really, to settle the ear. That's that bit of skin that peeled off the eardrum, so that it actually formed the shape of the eardrum. So it's probably about 1 centimetre in diameter. Well, I hope you enjoyed that video, guys. Take care, keep well, and speak soon. Bye.